Hello and welcome to the second in a series of Burnetts Solicitors webinars on rehabilitation. My name is Paul Brown and I'm Associate Solicitor within our Serious Injuries team here at Burnetts. I'm delighted that we are hosting this webinar in conjunction with smell loss charity Fifth Sense and dietetic company Red Pepper Nutrition. For anyone that doesn't know about Burnetts, we are one of the largest law firms across Northern England with our head office based in Carlisle. We have offices in Newcastle, as well as 3 offices across Cumbria, in Carlisle, Penrith and Cockermouth, supporting clients from coast to coast. However, because of our national reputation, we support clients and their families across the country. I'm very proud to work for Burnetts and support patients and families following serious injuries, including traumatic brain injuries, spinal cord injuries, amputations and other serious injuries. I've worked solely for claimants for 19 years, and our team of specialists, personal injury lawyers, have extensive experience of supporting people following head and brain injuries, which often leads to loss of smell and taste, which is discussed in today's webinar. I hope you find the webinar helpful, and should you have a patient or family that requires legal advice regarding a head or brain injury or other serious injuries, then please don't hesitate to contact me. My full contact details are set out below. I'm very happy to speak with patients and families free of charge, confidentially, and without any obligation to proceed. So moving on to the webinar, I have the pleasure of introducing today our experts whom have kindly agreed to support the webinar today. So our first speaker is Professor Carl Philpott, who's Honorary Consultant ENT Surgeon and Rhinologist at the James Paget University Hospital based in Norfolk. He's also Professor of Rhinology and Olfactology and Director of Smell and Taste Clinic at the University of East Anglia, and a co-founder and trustee of Fifth Sense, the smell loss charity. Professor Philpott is going to talk to us about the causes and treatment of loss of smell and taste loss. Our second speaker today is Nina Bleasdale, who is the Director of Development and Operations at Fifth Sense. Nina is going to talk to us about the fantastic work and support that the charity Fifth Sense provide to patients. Our third presentation is a joint presentation by Duncan Boak, the co-founder and chair of Fifth Sense, as well as Sian Riley, who's a registered dietitian and director of Red Pepper Nutrition based in the Northwest. Sian is an experienced dietitian, and Red Pepper Nutrition specializes in rehabilitation nutrition following traumatic brain injuries and other serious injuries, and they provide private dietetic services across the Northwest and beyond, with their goal to optimize food intake and nutrition for rehabilitation and independence and to prevent future disease and illness. Please remember that our webinar today has been recorded to allow it to be shared widely and hopefully increase awareness of loss of smell and taste conditions following head and brain injuries, and importantly, what treatments and support are available for this group of patients. If you have any questions, in order to keep the conversation going, please use the hashtag and Anosmia awareness on Twitter. Now I'll feed you over to the next speaker. Thank you.
Hello, my name's Professor Carl Philpott, and I'm Director of Research and Medical Affairs for Fifth Sense and Professor of Rhinology and Olfactology at the University of East Anglia. So in this talk, I'm going to tell you about post-traumatic olfactory dysfunction, really looking through the various aspects of smell loss related to head injury. We'll have a look at how common smell loss is and where head injury related smell loss fits within that. I will talk you through mechanisms of injury, have a look at about assessment and investigation of this type of smell loss, how we manage these cases, and also the prognosis for those affected. So how common is smell loss overall, and what are the overall causes? Well, smell loss is thought to affect at least 1% of the population, with smell disorders of some sort thought to be over 20%. If you look at studies where participants have been asked to self-report smell dysfunction, then smell loss itself varies between 1.4 and 15.3% across these various studies. Where studies have actually looked at testing people's sense of smell in a population base, then the prevalence of smell dysfunction actually rises to somewhere between 2.7 and 24.5%. So it shows that the reliance on people self-reporting is actually a little bit limited. We look at the surveys that have been done around smell loss over the years. Going back to 1986, the National Geographic did a survey where 1.2% returned scratch and sniff booklets and questionnaires rating themselves as anosmic. More recently, in 2012, in Barcelona, a Spanish newspaper survey sent out scratch and sniff smell tests and questionnaires, and they found a rate of anosmia, that's complete loss of smell, between 0.3 and 0.8%, but with hyposmia ranging between nearly 20% and nearly 50%. Interestingly, the risk factors they found for poor smell function included male sex, low educational level, previous head trauma, and pregnancy and overall age. You can see on the right here the graphic from another survey that was done in 2013 that summarized all the previous surveys up until that point. And you can see there that the top cause is sinonasal disease, so things like chronic sinusitis. Next down is respiratory tract infections, so we're thinking about viruses, common colds, influenza virus, and obviously now coronavirus. The next most common cause is people with no attributable cause, so we investigate and find nothing at all. And then the next one is head injury, and so it's really sort of in the top 4 causes of smell loss. How does that compare to other sensory losses? Well, loss of smell, if we're saying is at least 1%, then it's equivalent to sight loss in the UK, and also equivalent to profound hearing loss. And yet, obviously, as things stand, we don't have a Royal National Institute to consider and account for patients with those disorders. Finally, looking at the overall commonality in a practice-based setting in ENT departments, you can see, for those that don't speak German, that the slice of the pie on the right-hand side of the graphic there demonstrates inflammatory disorders of the nose and sinuses. The next slice of the pie is the one indicating other nasal problems. Then we've got viruses, the unknown causes, and then 5% of cases indicating head injury. So in an overall ENT clinic scenario, it is a smaller proportion of all causes of smell loss that we see. However, for those of us that do specialist clinics, you'll see that head injury is a much more common presentation. And you can see here that the bars indicated by PTOL, that's post-traumatic olfactory loss, is one of the most common reasons for people to present to my smell and taste clinic. So we think, however, this is obviously somewhat of an underestimate. In head injury clinics, then perhaps around sort of 10% of patients are reporting smell loss, probably not really getting much further action from there. As I've demonstrated in specialist smell and taste centres, obviously this is a much more common presentation. And one of the problems is that when people have mild injuries, they may not realise that they actually have smell dysfunction, and this only comes to sort of they only realise this later on. And of course, with people with severe injuries, often they've got a lot going on. They may be in intensive care for a period of time. They may be unconscious for a period of time. And I guess, therefore, firstly, they're probably not in a situation to be aware. And when they are aware, perhaps they're not a priority, or this loss of smell is not a priority over their other injuries. One of the things I hear from many people that have been in a situation where they've been admitted to hospital following a head injury is that when they are conscious and they're eating food, they naturally assume the fact that they're unable to detect any flavour in the food is simply due to the poor quality of hospital food, and not necessarily because they're actually not able to smell. If we have a look at the demographics for head injury, then there are sort of 2 groups really. There's the younger people who inevitably suffer sports injuries and assaults, and then the older people who suffer falls and car accidents. Obviously, those things are not exclusive, so we do see young people with car accidents, and also I've seen several patients who unfortunately have been the victim of assaults who are older. it's thought that about 1 in 3 motor vehicle accidents involve the head and neck region, and therefore not surprising that loss of smell may accompany that. Now, there are various mechanisms of injury for post-traumatic smell loss, and it really depends on whether it's high impact or low impact. And the other key thing is whether there's any associated facial injuries. So an assault that involves the nose, or perhaps a car accident where the face has gone into the steering wheel or the dashboard, obviously likely to cause an additional component that may cause a physical blockage inside the nose. So why does the sense of smell get lost? It can be because of bruising of the brain, what we call a contrecoup injury. It may be due to stretching or severing of the olfactory nerve fibers as they pass through the skull base from the nasal cavity into the brain cavity. Obviously, as I mentioned, it could be associated with a nasal injury, and it may also be that an individual patient already has a pre-existing problem with their nose and sinuses, and that the head injury exacerbates an underlying disorder. So in terms of the conductive component, you can see on this diagram showing how a fracture of the nasal septum could reduce airflow to the top of the nose, and therefore reduce smell performance. Only about 15% of the air that we breathe in through the front of our nose typically reaches the smell receptors. So if you affect that further by having a break or a fracture in the nasal septum, that percentage can go even lower. Sometimes if you get a deviation like this, it may also cause a secondary problem with blockage of the sinuses, and you may therefore got a further inflammatory situation occurring on the back of that. So as I mentioned, key areas of injury will depend on really sort of the way that the head is injured, the way the head's thrown back and forth. Sometimes that can result in bruising of the brain. Sometimes there can be a shearing motion which can stretch or tear those fibers, as you can see in the diagram here. But also, obviously, direct trauma in this area, particularly if it fractures the frontal bone, may obviously sort of injure the brain directly there as well. One of the other theories is that sometimes the injury itself may not cause a direct tearing of nerve fibers, but it may induce swelling around the area where the nerves pass through the skull base, and this in turn may compromise the blood supply. And therefore, what actually happens is that the nerve cells die because they're not getting sort of fed adequately. So there are various sort of places in the brain where we can see the injury. So the olfactory bulbs can get sort of rubbed along the rough skull base, and they can be injured. A lot of the time we see changes in this area at the front of the brain here that we call the orbitofrontal cortex. This is one of the key areas of the secondary cortex for olfaction. Obviously the frontal lobe in general, the temporal lobe over here, and the amygdala. So if we think about the severity of brain injury, so in cases where we scale the traumatic brain injury to be of a grade 1, that's a lower grade, then the chance of olfactory dysfunction is around 18%. In cases where there's a more severe injury, so grades 2 and 3, that goes up to 57%. So obviously the higher the mechanism of injury, the worse the potential outcome for smell. In terms of improvement, you can see from this graph here, sort of looking at months after the trauma, the greatest chance of improvement obviously is in that first sort of period between up to 12 months. Obviously there is a potential for improvement after that period, but it becomes much less. Studies that looked at longer term outcomes up to 10 years show that perhaps about 1 in 3 may see improvement over that sort of timescale, but it will really depend on the location of the injury in the brain. So when we're meeting these patients in clinic and talking to them, obviously key to go through the history carefully, find out about the injury. Sometimes that may be difficult, particularly if the patient had loss of consciousness and doesn't really remember much around the injury. If there has been a witness to the injury, obviously that may be useful. If they've been in a car accident, so details of the kind of speed of impact and damage to other vehicles may be useful. obviously looking for the fact that the timing of onset appears to have a relationship to this head injury rather than being a sort of gap between. Obviously, that has to account for any problems where they might not be able to be aware of it, such as being unconscious in hospital. Therefore, if their first time of being aware of loss of smell was perhaps coming out of hospital after a head injury, then that may be an appropriate time scale. Sometimes we get people that come to clinic where there's been a head injury, they've also had a bad cold, they may have taken some medication, so there may be several factors in there, and so it's important to sort of try and unpick those and work through and exclude any relevant issues in the background. Obviously important to know if people have any other symptoms from their nose. As mentioned, obviously if they've had a deviated septum as a consequence of a facial injury, then we'd want to know whether they have any issues with blockage or breathing through the nose, whether they have any discharge from the nose. Also keen to know if they have any clear fluid dripping from the nose that might indicate a fracture of the skull base and a leak of brain fluid. Some patients may experience what we call qualitative disturbances. So the most common one is phantosmia. There they get what we call phantom smells or imaginary smells without the presence of any odour in the environment around them. Important to unpick true taste. Can they detect salt, sweet, sour, bitter, and umami? Some patients who have injury to the cortex, the brain itself, may also get adjacent damage to the taste areas in the brain, but a lot of the time the problem is around the smell function, and so when you unpick this, the patients have only a flavour issue perception, not a true taste problem. Important to obviously look at other things, so any drugs they've taken, perhaps relating to their admission to hospital if they've been in hospital. Also to understand their expectations, understand their work situation, their home situation. How does the ongoing impact of this smell loss in context of their work affect them? So in terms of investigating the situation, the next step after talking to them is to examine the nose, and again just to check that there is no sort of evidence of any blockages or any pre-existing problems in the nose that, if treated, may help to improve the situation. If we see things in the nose, then it may be inappropriate to undertake a CT scan. In cases where the nose looks normal, we said this is a simple post-traumatic case, then an MRI scan is really the most useful investigation to try and delineate any evidence of an injury or site of injury. Also very important to perform smell testing, because people's description of their performance or their subjective reporting of their performance and how they actually perform on smell tests can be two different things, and useful from our point of view to know whether they have any residual function in sense of smell, because that may then guide us as to where we go forwards with any treatment. So in our clinic we use something called the sniffing sticks test. So you can see there are three components to the test here. This that depends on the left is what we call an identification test. So it's really sort of asking people to smell the pen, and they have a choice of 4 options to choose from. Obviously this requires some prior familiarity with the odours concerned. And the other 2 parts of the test, we do discrimination and threshold. So for discrimination, we're asking the patient to tell us which is the odd one out of the 3 pens in each set. And this obviously doesn't require any prior experience of the odours. They're merely looking to tell us the difference between the one that's different from the other 2. And the third part of the test, the threshold, we're really looking to, again, for them to identify that there is an odour present rather than a blank, as in 2 of the pens will be blank. And then we work out how small a concentration of the odour they can detect, and that sort of gives us a kind of level of performance. And this is principally what you get at the end of it. So this is actually my smell test when I had sinusitis. So you can see I had a threshold here that was a little reduced, so towards the top of the scale here. I got 11 responses right on discrimination, and I identified 10 odours correctly on the identification test. Other things we might consider doing include taste testing if we think there has been problems with true taste performance. And occasionally we might also consider doing what we call a retronasal test, which is to mimic the perception of flavour, which is when we put food powders in the mouth, and we're actually asking them to essentially smell them, but they have to identify the odour from one of 4 options on the test kit. This is just to emphasise really why we do smell and taste testing, because when we see people in clinic and they tell us about what their problem is, they typically have a complete mismatch from what we actually see on the tests. So a lot of people will talk about smell and taste loss because of the issues they have with separating the 2 functions. In reality, you can see here that only 1% or less actually have a true taste loss on testing. So as I mentioned, with traumatic cases, we will do an MRI scan, and that's really to look at any evidence of what we call gliosis. That's sort of, scarring and changes in the nerve tissue of the brain in response to previous trauma, particularly in the area of the brain at the front of the head, and what we call the olfactory bulbs, which are like the relay stations for the smell nerves as they come out of the nose and connect to the ones that go into the brain. We talked about endoscopy already. So here you can see examples. This is a sort of scan here where you can see this marked gliosis in the orbitofrontal cortex here on both sides of the brain. So this is a sort of poor prognostic sign when we see this on the scan. Here you can see evidence here of some changes in that area at the front of the brain as well. Here's an example of a clinical case we saw. So a 39-year-old male athlete suffered a head injury while cycling, unfortunately, despite wearing a helmet. He had a closed hand injury and was reserved in hospital with a period on the intensive care unit. He noticed his apparent loss of taste after hospital discharge. At the point of seeing in clinic, he experienced depression and also noticed change in personality. If we look at his scan, he had really kind of dense gliosis and changes in the frontal lobe here. So this accounted for both his smell loss, so it was really a smell loss and a taste loss, and also his personality change. So this unfortunately was not something that we could do anything further to remedy. So really it's about conservative and supportive management in that scenario. So in general, when we're looking at managing these cases, one of the key things that we can advise people to do is smell training, and I'll talk a little bit more about that on a subsequent slide. We obviously need to sort of counsel patients as to the reality of any recovery and how they manage their situation going forwards with a lost sense. If a patient has a normal MRI scan, so I haven't seen any sign of any injury on the scan, and if they're within 12 months of injury, and particularly in younger patients, I would look at giving them a course of oral steroids. There is a study from Taiwan that supported giving a course of prednisolone for 3 weeks along with zinc supplementation for 4 weeks. That suggested that there may be better outcomes in that particular group. The other thing, I guess, that will sort of influence treatment will be if there is some preservation of olfactory function. Now, there are a number of other studies that have looked at sort of medical treatments where patients with head injury have been included, and there have been some variable sort of reports of selective improvement. But I guess it really depends on the sort of the underlying sort of site of injury. And again, if the MRI scan is normal, then I may talk to patients about considering these if they're early in the process. Obviously, if we've noted any problems in the nose, such as a deviated nasal septum or any problems with the sinuses, and if they're additionally symptomatic from that, then it's only worth considering correcting that and talking to them about the merit of doing so. So smell training is really a very simple but key thing that patients can do. This has been really evidence-based now for best part of 6-7 years. A number of studies have looked at this, and including patients with a head injury, and certainly in the head injury group, we can see that you can see here patients on the red line starting smell training, patients here without smell training, and you can see there that the overall improvement of a group of patients doing this with head injury is that at this stage the sense of smell isn't back to normal, because this is the sort of scale for the smell test, the sniffing sticks. So we would consider above 31 as being normal. But certainly at this level, it suggests that they're starting to detect something rather than nothing. And you can see there's obviously a difference here to the control group. So certainly for these patients, it can provide some benefit in selective cases. Fifth Sense has on its website some self-help guides here, so the smellability toolbox, and this is a good resource for patients to go and look at in their own time. So as just really sort of summarising, what are the features of people who improve? Those that tend to sort of benefit from the olfactory training tend to be younger, have a shorter duration of the disorder, and less severe trauma. So getting people to see a specialist sooner rather than later is always beneficial, and sadly I still see people who come in, you know, 1, 2 years, sometimes several years after a head injury, hoping for some treatment. Where there's evidence of frontal lobe damage, particularly bilateral, then this is a poor prognostic sign, and I'm always sort of careful to counsel these patients that they're much less likely to experience any improvement as a consequence. So what other things can you do to help them? Well, so you can talk to them about sort of domestic adaptations and hazards, making adjustments both at home and in the workplace. Think about how to improve their diet to avoid weight loss or weight gain. And thinking about sort of personal hygiene, and also really sharing the problem with friends and family so that people are aware around them, because they won't have any visible stigma on the outside that they have this smell loss. So people won't understand that they have a problem. And so the more people they can feel able to share it with, the better it will be for them to manage the situation going forwards. This is an excerpt from a book by Ron DeVere and his colleague Marjorie Calvert called Navigating Smell and Taste Disorders. And they did some work on looking at enhancements for various foods with spice combinations that may improve palatability for patients with smell and taste loss. The other aspect of head injury is the qualitative disturbances. We talked about the phantosmia earlier. And after a head injury, this is sort of very common scenario. There are some conservative things that people can do at home and under their own steam. So simple things like performing the Valsalva maneuver, head movements, stimulating the nose with other smells, which is principally the smell training, nasal douching, deep breaths in through the nose, and also trigeminal stimulants, so things like menthol, horseradish, mustard, capsaicin. However, if this is problematic and those simple measures aren't working, then we may need to consider, if we haven't gone down the route of using medical treatment for a quantitative issue, then whether dealing with this sort of qualitative aspect head on is appropriate. And one of the key things that I found useful for these group of patients tends to be gabapentin. This is an anti-epileptic drug, and can help to modify the sort of phantosmia sort of perception, particularly if people are finding it really kind of disabling and disheartening. There is a description of a case series in the literature around surgical removal of the olfactory epithelium for severe cases of phantosmia, but this isn't really something that any colleagues sort of practice generally in smell and taste scenarios, and I've certainly not had to resort to this to date. So just a final mention on prognosis. As I say, we can see partial recovery in about 1 in 3 people after head injury related smell loss. And complete recovery probably only occurs in about 10 to 15% of cases. The significant factor really is about, is there any residual smell function? And any recovery is most likely to occur within 2 years after head injury. Actually, measuring the volume of the olfactory bulb can be a useful kind of marker for that. So when you do the MRI scan, you can look at the volume of the olfactory bulbs, another little thing that sit above the top of the nose. And when the sort of volume is higher, it indicates really the sort of performance of the overall smell pathway. And these things can sort of decrease and increase in size if there is some recovery of the system. So in summary, obviously you can appreciate that there are various mechanisms of injury causing head injury related smell loss. The prognosis is best in those who are younger and with lower mechanisms of injury, and treatment, if appropriate, will depend on the severity of the injury and the findings of the MRI scan. Well, I hope you found this useful, and if you have any further questions on the topic, please do send them through to my email address on c.philpott@uea.ac.uk. Thank you for listening.
Hello, I'm Nina Hill. I'm the Director of Development and Operations at Fifth Sense, the charity for people affected by smell and taste disorders. So who are Fifth Sense? These are our people. Our people are comprised of lots of volunteers, lots of people who give up their valuable time for free to raise awareness, take part in research, provide support and help others. We have UK ambassadors who are UK based and who provide contributions to research, they support other people, they work on our social media with us, and they use their skills and expertise to complement the work that we do. We have hub pioneers, and I'll talk a little bit about the hubs later on, and they facilitate our regional networks. We have international ambassadors. They are people who don't live in the UK and often live in countries where there is no charitable support for them, and they promote the work that we do, and they signpost people to us all over the world to receive our support and help. And we have a raft of volunteers that contribute to lots of different things all of the time, not just fundraising and helping with donations, but giving their time to attend conferences and help create them and create videos and contribute to research. Staff-wise, there's myself and my colleague Danny. Danny joined us in June this year to complement the staff team. I joined Fifth Sense in February of this year, following a career in the NHS. Which culminated in my final role with them as an Associate Director of Operations for Cumbria Partnership, and as part of my care group, Neurology, Acquired Brain Injury and Physical Health Psychology were services that I developed and managed. So hopefully I can bring that expertise to provide support to people with head injuries and neurological conditions. Our Board of Trustees comprises of Duncan Boak and Carl Philpott, both of whom are contributing to this webinar. Duncan founded the charity in 2012 following work with Carl that he was doing, and they are joined by Matt Jones, Zim Kanji and Esther Kirby. Our advisory board comprises of people with lots of expertise in the world of smell and taste. Sarah McCartney is a professional perfumer. Steve Wunger works at the University of Florida in the Centre for Smell and Taste. Rachel Hertz is a prolific TEDx speaker on all things senses, and Darren Logan is a scientist and researcher into smell and the function of smell and senses. So what is smell loss, and what do we do here, and what do we support? I made the mistake of referring to everybody with a smell disorder as having anosmia, and that's not quite the case. So you may see on my Twitter and on our Fifth Sense Twitter account the hashtag all the osmias to encapsulate all of the different smell disorders that that can occur. So there is anosmia, and generally speaking, these are the four categories where somebody has no sense of smell whatsoever. Hyposmia is where somebody experiences reduced ability of sensitive smell, and that's been described to me as being able to get a faint whiff of certain aromas and certain odours. Prosmia is where the sense of smell is distorted and often follows hyposmia and anosmia as the receptors in the nose change and shift and possibly regenerate. Often parosmia is very unpleasant, and it's described as a smell of burning rubber or a pungent chemical smell or raw sewage, and it's really not very pleasant to experience. And phantosmia is a hallucination of smell, of an odour that's not really there. And I speak from personal experience with this particular condition, which comes and goes for me, but it often smells as though somebody is having a cigarette outside the window. It's there in the background, it's real for me, but nobody else can smell it, and it isn't actually there. So in terms of having a smell disorder, there are a number of causes, and this list is far from exhaustive. Anosmia can be congenital, so somebody can be born without the ability to smell whatsoever. And that can be either damage to the olfactory bulbin system or no olfactory bulb at all. And people with congenital anosmia do not know what it is to smell because it's never happened for them. Or it can be acquired. And there are, again, lots and lots of causes that contribute to this, but the most common are sinonasal allergies, chronic rhinosinusitis, post-viral or post-infection, which we are seeing very prevalently at the minute with the COVID pandemic, as you've probably all heard. It can be a head injury or a brain injury, causes loss of smell, causes damage in the brain that affects the ability to smell. It can be other causes, it can be other comorbidities and long-term conditions that cause it, such as Parkinson's and cancers, age-related conditions such as Alzheimer's and dementia. But the most common cause is idiopathic, where there is actually no established cause that can be found for people. And the prevalence of smell and taste disorders is up for debate. Potentially, research has shown that around 5% of the general population have impaired ability to smell. In the UK, that would equate to about 3.5 million people potentially. It's also thought that some studies have suggested that up to 25% of people could have some experiences of smell loss, if you include people with age-related conditions. As we all know, as we get older, our eyes start to get worse, our hearing becomes impaired, our body starts to degenerate, and our smell is part of that also. True taste disorders are actually rare. So a taste disorder would be referred to as anosmia, with no ability to actually taste. And that would affect the taste buds on the tongue only and not rely on any nasal condition. Now, I've actually come across a member of ours who has no ability to taste at all, but can smell, which he has, that he's faced with different challenges. And so he can walk into a restaurant or a kitchen and smell garlic or something, some aroma cooking in the kitchen. When he puts it in his mouth, there is nothing, there is zero taste. And he told us that he acquired that as a result of a burst eardrum, a head injury on the football pitch where a football hit him particularly hard on the side of the head, perforated his eardrum and left him without the ability to taste. But it is much rarer than a smell disorder. Many patients complain of losing the ability to taste because they think it's taste that's affected, when actually it's the ability to smell, because smell creates flavour when you're eating. The retronasal olfaction that takes place between the mouth and the nose at the back of the throat when you are eating food helps us to discover those flavours, and it doesn't just rely on the true taste buds on the tongue, the sweet, the sour, the bitter, spicy, the umami. Sweet, sour, bitter, salty, umami. I apologise. So how does the sense of smell affect us? Smell is a sense that lives in our limbic system, and that means it affects our mood, it is affected by our memories, and ultimately it influences emotions. So when I think of smell, I think about it being not just here, but also here and also here. And we can all reflect on smells that are familiar to us, that we can recall from our childhood, for example. The smell of my nana's house, I can still think about that, and I'll get a whiff of going to someone's house with a similar aroma in there, and it takes me back 20 years, 30 years. But also the smell of your children. Although my children are almost grown up, I can still recall how they smelled as babies. And the impact of olfactory disorders can be quite profound. So Fifth Sense undertook a survey, a study in 2014 looking at the impact of olfactory disorders. Although there are physical impacts caused by smell and taste disorders, a lot of them are emotional, psychological, mental. 92% of respondents described how enjoyment of food and drink has been reduced because that flavour element isn't there. 85% described how they have fears in relation to safety. So they can't smell leaking gas or something burning in the kitchen or food that's spoiled in the fridge. 61% reflect that they experience depression and anxiety as a result of this loss. And for some, it can be a grieving process, this profound loss that they no longer have, and that can lead to mental health and wellness. 54% reflect relationship with families and friends have been affected, and because it's connected to that emotional limbic system, because it's connected to mood, memory, and that can affect relationships, and that's been reported to within this study. So what are the challenges? Well, they've changed a little bit since I last did this presentation or used this presentation. I'd like to think as a result of the pandemic, awareness in the medical profession certainly has improved and increased. But quite often people describe that they are told by their GP that there's nothing that can be done. It's something that's happened and it's something they've got to live with, which is quite powerful to hear when somebody is really concerned about something they've lost. Generally, a lack of understanding and empathy. So quite often people are told, well, it's only a sense of smell, it could be worse. You know, you can still see, you can still walk. And actually, you know, we get lots of emails and contact from people affected by smell loss. And somebody emailed us and said that they'd lost their sense of smell. It's been 3 days and they were terrified and anxious, and "man in the walls" was the phrase that they actually used. Initially, I thought, well, 3 days, you know, that's not very long. But then I reflected very quickly that if I suddenly woke up and couldn't see, I would probably go straight to A&E, get that checked out. And if I woke up and couldn't hear anything, I would probably contact my GP at the very least and get it checked out. If we wake up suddenly or we experience sudden smell loss, it's not something that people generally respond to immediately. I guess personally, there's a number of reasons that could be. We've probably all experienced a cold or hay fever or a sinus infection when the nose has become bung and we can't smell, it goes away and smell comes back. So it's a sense that sometimes and often goes away temporarily for lots of people. But also it's something that you don't immediately notice. So you might not notice the sense of smell has disappeared until you go to eat something, until you go to smell something, whereas sight and hearing would be instantly recognisable. And they're just my personal reflections on why that might be the case, that people don't think it's a sense that is as powerful as the others. There's also relatively little clinical research being undertaken, and certainly lots of clinical trials are on hold at the minute. And a lot of the research that's currently being conducted is into the smell loss associated with the pandemic, which ironically is a good thing for people with smell and taste disorders. That research is being stimulated and awareness is being raised as a result of becoming a much more common health condition that's affecting lots of people. It's also classed as an invisible disability to a lot of people experiencing it. It's not something you can tell somebody can or can't do. It does affect our ability to do certain things. So a chef may feel they can no longer cook to high standards because they cannot smell and taste their food properly. A gas engineer would be at risk if they weren't able to smell gas and that's what they were working with. So it certainly prevents the ability of doing certain jobs. The law around disability in the UK is very complicated, and I think I'm talking to lots of legal professionals, and you will know a lot more about that than I do. There's also a lack of awareness of the deep and profound role that smell plays in our lives. It's not something that we often realise until it's no longer there. And that's stories, we're hearing those stories all the time this summer as people's smell loss isn't returning as quickly as they thought it would be following COVID-19. And lots of people are saying, I didn't realise how important it was to me until I can no longer do it. So what do we do here at Fifth Sense? Well, we provide support, advice and guidance to people through the resources on our website and through conversations that we have and through contact with people. We contribute to research, we undertake research projects, and we engage our members in research projects so that people can be involved in developing research into the future. And we also educate both people, the general public, people affected, and clinicians about smell and taste disorders and the impact of them. I guess that's what we're doing today. And who we work with? Well, we work with lots of different people. We work with people affected by smell and taste disorders and their families. We work with the general public in raising awareness. We have collaborative and commercial partnerships. And we also work with scientists, medics and clinicians. So some of the work that we do involves awareness raising with the general public. Now, if I was in the same room as you, I would be asking at this point for a volunteer to come and take a jelly bean or a skittle and a nose clip and pop the nose clip on and taste the sweet. But I can't do that physically today, so I'm going to show you a video of someone doing just that.
Anosmia Awareness Day, and fifth sense here at the English National Opera with Chief Executive Stuart Murphy. We're going to talk a little bit about the importance of sense of smell. And the first Stuart, pop his nose to the pump. Again, pop the nose to the pump. So this is the fifth sense nose to challenge. Take a jelly bean. Pop it in your mouth and start chewing. Don't swallow. Now, what does it taste like? Nothing really. Take the nose to the top. Wonderful. Yeah. So mango. Right, brilliant. So did all the flavours rush in? Yeah. So that's the impact. That's how the sense of smell contributes so much to the overall flavour. When molecules move inside our mouth, parts of the back of the mouth into the nose, sense of cells. So when we're eating and drinking, that's smelling the food inside the mouth as well. So how important
That was Stuart Murphy, the Chief Executive of the English National Opera, undertaking the Fifth Sense Nose Clip Challenge on Anosmia Awareness Day earlier this year with Duncan, our founder, and hopefully that explains to you how nose works with the mouth. But I would recommend on your way home tonight, maybe you buy a bag of jelly beans or a bag of Skittles, and you ask your family and friends to do the challenge. And in lieu of a nose clip, just pinch your nose really tightly so that you can't breathe through your nose, and pop the jelly bean or the sweetie in your mouth and try it that way. So we also undertake some work with commercial partners, and we're currently working with Paget, who are gas distribution provider, and so they enable all of our gas to get around the country, and they are supporting us in safety awareness raising, not just about gas but also about other aspects. And we're also working with Flavour Active, who are a company in the beverage industry, and they're helping us to develop tools to help people explore and understand how they can taste when they can't smell, how they can test their taste, and how they can make changes to the way that they use food and eat food and enjoy food when there is no ability to smell. And we also work with some research partnerships, and there's a couple of short videos that I'm going to share with you now to explain what they are. The Global Consortium for Chemosensory Research, the GCCR, is a multinational collaboration. It's not an organisation, it literally is a collaboration. I sit on the leadership team currently to represent patients and their needs. So when the scientists are undertaking research and putting surveys together, my role is to think about how a patient might perceive that and how the public will respond to the questions that are being asked and make sure the language is correct and that we're not missing something that's important to patients. And I take part in a patient advocacy group that contributes to that. So this is what the GCCR has been doing, not directly relevant to head injuries, certainly tells you a little bit about the importance of researching smell and taste.
Help researchers worldwide better understand the relationship between the loss of smell and taste and COVID-19. Studies in March 2020 found a high incidence of smell or taste loss in people who tested positive for COVID-19. As the virus spread, Google searches related to the loss of smell and taste spiked in places where the virus has now taken hold. The correlation became apparent, and investigators around the planet took notice and began to discuss if the loss of smell and taste could be an early symptom of COVID-19 infection. What followed, in a matter of days, was the creation of the Global Consortium for Chemosensory Research, an international grassroots effort by scientists, clinicians, and patient advocates to better understand the emerging connection between the loss of smell and taste and COVID-19.
The GCCR started with one email, which in a matter of hours exploded into hundreds of emails from scientists worldwide who wanted to come together to study taste and smell loss in COVID-19.
What we are trying to do is really bring also the expertises from different disciplines and also the cultural backgrounds of international colleagues together to approach the questions of how taste, smell, and kinesthesis are affected by COVID-19.
Right now, the GCCR is requesting that people who have recently had a respiratory illness take a simple online survey that will help the consortium in this global data gathering effort. You can contact the GCCR to complete the online survey on Facebook and Twitter or on their website. So if you have had a cold or the flu within the last 2 weeks, or if you are recovering from COVID-19, take the survey today.
And the other major collaboration that we are currently involved in is the James Lind Alliance Priority Setting Partnership for Smell and Taste Disorders. Fifth Sense are running this priority setting partnership, and we are following the guidance and the framework of the James Lind Alliance, which is part of the National Institute of Health Research. We have provided and we have brought together a steering group which comprises of clinicians, patients and their families, and we'll be working in partnership with other organisations, other partners of the third sector organisations to enable the research work to be spread as far and wide as we possibly can, so that people with smell and taste disorders can contribute to the survey, and it's developed in conjunction with patients who experience smell and taste disorders. I've got a little short video to show you which explains what it is and what it means to people affected by smell and taste loss.
James Lind Alliance Priority Setting Partnership for Smell and Taste Disorders is incredibly important to us at Fifth Sense, and it's the result of 8 years of preparatory work. When smell and taste loss became an executive COVID-19 virus, it became apparent that the time was right to capitalise on the decreased awareness about smell and taste and to prevent the PSP looking into all aspects of smell and taste disorders. The steering group comprises patients and carers representing the causes of smell and taste loss and the different ways they present. Clinical representation is included from ENT, Rhinology, Psychology, and Primary Care. It is professionally led by Professor Philpott, who is supported by an operations team. The PSP launched on 26th of September, and we will continue to keep you updated, engaged, and involved to develop the survey in the coming months.
Because for me, when I was diagnosed, there just wasn't any sort of research. With research comes understanding of anosmia, which is so important, especially now with COVID-19. But also with research and understanding, there comes that element of support, which can sometimes get neglected when you're first diagnosed.
I don't think it can be understated how much smell and taste loss can really affect people and the people around them. But anything we can do to increase knowledge in forms of research and to help clinical professionals to concentrate on these areas can only be a good thing in the long run.
It would just be great to have more understanding about the condition, more treatment options, and more understanding of the impact it has on people who have this condition.
In my case, I would love to know why I was born without a sense of smell. So I have no olfactory bulbs whatsoever. So I would love to know why that was the case.
To work with the James Lind Alliance, it's an incredible honour, I think, and together we can really make progress in this area of research.
The knowledge about it, hopefully this steering group will help publicise it, but don't be afraid to talk to someone. It's not an embarrassing thing, it's actually quite an amazing thing to talk about.
Because I think there's a lot of unanswered questions in so many different areas of taste and smell disorders, the priority setting partnership is just incredible. And I think with COVID hitting at the same time, there's never a more important time for this condition to be better understood and for research to happen to help sufferers like me, because it will make a huge difference to us.
There's nothing more powerful than hearing a patient's voice explain why it's important to them. And ultimately, the aim of the priority setting partnership is for the steering group to disseminate all of the information that comes through, to devise a questionnaire that establishes the 10 priorities of research for people who have a smell or taste disorder. So in terms of the work that we do, we also, I referred earlier to a regional hub. So we have Scotland and Newcastle, the North East, up and live. So these are regional networks of Fifth Sense, which are run by a volunteer, a hub pioneer, in conjunction with a clinician that supports them. And it provides a network of peer support for people in that area where they can come together, share experiences, go out for lunch and experience food and talk about the textures and what they can taste, discuss treatments with the clinicians that are involved, also engage with other organisations for mental health support and wellbeing, etc. But we've got plans to launch our Liverpool Northwest hub very soon, probably in the new year. And later on next year, we will be launching hubs in the Midlands and the South East. And we hope that these will provide resources for people to link up with people like them that live nearby and develop a network of peer support and raise awareness. But because we can't do that, what we've done this year is create online conversations where we're bringing people together from all over the world to talk about smell and taste, which is why we call it #Let's Talk Smell and Taste. Most of them are conversations, and they are not in large numbers, they are less than 50 people. We use Zoom to be able to facilitate these. They are hosted by one of our fabulous volunteers. And we often have guest speakers that contribute and give presentations. So we have a number of medics that have discussed medical conditions, and you can see the programme there. So up and coming in December, we have a session which Philpott is leading on head injuries as a causation. We've also looked at COVID and allergies and post-viral, and we'll be running a raft of these again next year. We also look at smell training as an interactive session that people can attend and learn about smell training and go away with ideas about how to do that best for themselves. We have a session on how to keep safe. We ran a session on how to support somebody who has a smell and taste disorder. So if you're the person that makes the food in the home or looks after a child with smell loss, that session's for you. And we are open to any new ideas about subjects and topics that people would like to talk about. They're all private and contained, so the people attending can speak freely and in confidence. The webinars we video and then publish because they're to a much wider audience and they're much more a presentation style. So we mix it up so that we keep people interested, and our events usually sell out by the end of the day that we launch them. So our next draft will be released next week for the rest of the year, and then we'll be working on a programme for the following year. And the feedback that we've had from these is that it's been incredibly powerful and impactful, and people have gone away feeling like they have done something meaningful and connected with people like them who understand the challenges and the successes of living with a smell and taste disorder. And we also have a toolkit called Smellability, which is testing and measuring and monitoring and training sense of smell. Just share this with you because this is the one that you can see on our website and download the resources from. So there is quite a lot of information on this page about the science behind smell training and the importance of baselining smellability before you start smell training. There is also a test on there that you can use very quickly to establish sudden loss of smell that's potentially COVID-19. And there is some tools on there to help with smell training, either with things that you have at home in the cupboard or using essential oils, which is the foundation of some of the scientific training that Thomas Hummel has undertaken at the University of Dresden. And I have one final video that talks about how to smell train at home without purchasing any kits or any essential oils.
Hello, my name is Sarah and I make perfume. So, what might you have hanging around in your house that makes a lovely aroma that you can start to use to build your own sniffing set? Well, how about an orange? Citrus fruits of all kinds, the essential oils actually come from the peel, so when you start to peel it, they leap out at you and you fill the space around you with the aroma of whichever citrus fruit you have chosen. You can grind these, and I find that the aroma, actually you get quite a strong aroma from the pot itself rather than just the bits that you ground, but some of the aroma stays nicely in the grinder bit where it needs to reach down. I have, well, in a handy vitamin pot here, because I was brought up on good pizza, don't throw anything away when you use it. I've got bay leaves in here, crushed bay leaves, which have been growing in a pot. Mint, slightly sad looking piece of mint here from another pot, but still rub it and immediately get the smell coming off it. The aroma is from the essential oil of peppermint here, so there you go. Oh yes, and the sprig of rosemary actually nicked from the neighbour's this morning, but it's probably best to ask for. Yeah, again, you rub this, snap one of the leaves, and what you get is the essential oil aroma of rosemary coming out at you. So you can take these, you can put them in pots. I've got loads of pots around this place, but you can get them off eBay not too expensively, and you can stick stuff in them. So you can squirt fragrance in them and just sniff from the top. Yeah, this one smells of lemons, lemon grass, fennel. So just actually let it dry in there, coat the inside of the bottle. Something like that. What else? What do you put in things like this? Coffee beans, that's a good one. Squirt of your favourite shower gel. Honey, Marmite, soap. So things are hanging around probably close to where you live in your kitchen that you can start to use to build your own.
There are tools in our toolkit. Some, as I say, are in development and not available just yet, and so a bit of a sneak preview. That's us, that's 5th Sense, and that's how you can contact us. You can see what we do on our website, www.fifthsense.org.uk. You can find us on Twitter at 5th Sense UK, Facebook, 5th Sense UK, LinkedIn, 5th Sense UK, and Instagram, 5th Sense UK. Or you can email us at info@fifthsense.org.uk.
Hello, my name is Sian Riley, and together with Duncan we are going to do a bit of a double act today, presenting on food and the sense of smell. Our Twitter handles are there, so please do follow us on Twitter and use the hashtag Anosmia Awareness, and we can keep in touch during the presentation. So a little bit about me. I'm on, my name's Sian Riley, I'm on LinkedIn there. I started off my career as a research scientist for the pharmaceutical company AstraZeneca, looking into targets for obesity and diabetes. I loved the work there, but wanted to see the bigger picture and to work with people. So I retrained as a dietitian and worked in the NHS for a number of years. I made the brave step into the world of freelance and set up Red Pepper Nutrition, where I specialise in working with people following a traumatic injury. It's an area that I absolutely love, and you can see a real difference in working in the area of nutrition after traumatic injury. I am a founder of Red Pepper Nutrition, but I'm also a business mum. I'm a mum of 3, which has been great fun over lockdown, as I'm sure you can imagine. But it does make me a practical and realistic dietitian. I very much feel that food needs to fit into our life and fit into the chaos and not the other way around. So having children produces many of these skills.
Hi everybody, so I'm Duncan Boak and I'm the chair and founder of Fifth Sense, the charity for people affected by smell and taste disorders, which I started setting up in 2012. The starting point of this was me losing my sense of smell through a head injury in 2005 when I was 22 years old. I fell down a flight of stairs on a night out with some friends and landed on the back of my head, and came out of hospital and realised I couldn't smell anything. And I still have no sense of smell, or anosmia as it's called, to this day. In spite of this, I'm a big food lover and a really keen cook. And I'm really interested in how to make use of our other senses in cooking, eating and enjoying food. And my work with Fifth Sense is done around a full-time job managing a business centre at the University of East London, which has also been quite an interesting task during lockdown.
Okay, so in our double act today, what will we be talking about? We'll be talking about the importance of nutrition in acquired brain injury rehabilitation, talking about the important link between smell and appetite. How does smell loss fit into dietetics? The dangers and the consequences of smell loss, and what we can do to help as professionals, but also as carers, as families and as friends. So I would like to start off by discussing the importance of nutrition in brain injury rehabilitation. I believe nutrition is very much the foundation of rehabilitation. And I want to use an analogy to explain this a little bit more. So you've probably heard the phrase, my body is a temple, and our body very much is a temple. It's a really busy temple that's getting lots of knocks and bangs all day, every day. Thankfully, we've got some workers who work hard in our temple 24 hours a day, 7 days a week, to repair and maintain any of the damage that's going on. And they do this by going to storage rooms. So if there's say a knock on the door that needs repairing, the workers will go to the storage room and get the right material for the job to repair it. So if there's a knock on the wall, they want plaster, they want paint. They're not going to go to the storage room that's got the bricks in. These storage rooms, you've probably guessed, are our nutrient storage rooms. And we need these storage rooms to be as full as possible. And when all the different nutrient storage rooms are full, our body can heal and repair itself as efficiently and as effectively as possible. There are many reasons why people's storage rooms won't always be full. You might, in the example of, say, a teenager, they're growing so fast so they're depleting these storage rooms really quickly. You might have somebody who's excluding certain foods from their diet, or they might just simply be dieting, and they may find that some of their storage rooms are lower than others. After a traumatic injury, it's like an earthquake has hit our temple. The damage that's done to the temple is immense. The workers get to work straight away to repair the damage, but this means that they need a lot of the materials from the storage room. They need a huge amount of nutrition. So quite often these storage rooms are getting depleted very, very quickly. If someone after a traumatic injury is in hospital, then the medics and the hospital dietitians will be working really hard to replenish these storage rooms, replenish the nutrient stores. And they'll be doing this possibly through nasogastric feeding, through nutritional supplement drinks. But it really is very difficult to keep on top of the huge nutritional requirements that happen after an injury such as this. For many people after a traumatic injury as well, it's not just the earthquake that's the problem, it's also these aftershocks. They may be going into further surgery, They may pick up infections in hospital, and all these things are going to act like aftershocks to the earthquake. They're going to cause further damage. They're going to deplete the nutrition store even further. And obviously our talk today is about smell loss, and that this is a further aftershock to our temple. So quite often after an acquired brain injury, the rehabilitation phase actually starts in a state of malnutrition. So it starts where our nutrient stores are low.
Thanks, Sian. A lot of that really resonates with me, thinking back to the weeks and months following my head injury. So I was in hospital for a week after the accident, eating very little. I think I was, apart from being pumped full of morphine. And it was when I came out of hospital and I had the first meal, my first meal since the accident at my parents' house, and I realised I couldn't smell anything. It didn't taste of anything. I went to see my doctor to say I've lost my sense of smell, had a really bad head injury, but you know, do you know anything about this? And I was told, we don't know anything about it, nothing can be done, give it time, it might come back of its own accord. If it doesn't, you just have to live with it. And my attitude at the time was, I felt I was lucky to have only lost my sense of smell. To me, it was, you know, I'm fine, I just can't smell. But I think it's fair to say that it, you know, ran a whole lot deeper than that. I became very depressed in the months after the accident. I lost my appetite. I lost weight. I'm a pretty slim guy anyway, and I lost about 1 stone, and I was like a bag of bones for a while. And the thing is, with loss of smell, there is a lasting, ongoing loss of quality of life. And we're not just talking about the eating experience, we're talking about this removal of a really important emotional connection to the world around us and to people in it. It really impacted on my ability to form close personal relationships with girlfriends for a long time. And there's this ongoing feeling of disconnection, of being removed from the world, of watching life from behind a pane of glass.
Okay, so I'm going to show here a YouTube clip. Here's one I did earlier, and looking at, with no smell, how many flavours of jelly beans are there. I'm actually going to talk over this because the sound doesn't seem to record on it. So this is me, all in the name of science, you understand, eating jelly beans. So I've got a number of jelly beans there, a huge number of flavours, so I did end up cheating slightly and put a few flavours into a little container to give myself a chance. So what I'm going to do is I'm going to hold my nose so that I'm not getting any of those smell, that ability to smell is gone. I'll show you the colour here so you can just see it's a brown one, but I can't see that. And in my mouth I'm chewing it and I can taste the sweetness. It's very sweet, but that is all I can taste. I don't know what flavour it is whilst I'm holding my nose. You'll see now I take a big breath in and suddenly the flavour hits me, and it's coffee. So you can see whilst holding my nose, I can't decipher the flavour of coffee. All I can taste is the sweetness. And I'd say try this yourself. If you're having your lunch, just have a go with holding your nose and see if you can taste the food.
So what Sian's doing there was a bit of a welcome to my world, in terms of, you know, removing the ability to perceive flavour. So what are taste and flavour? Well, I like to think of it as being like a flavour being like a house. where taste provides the foundations. And when I say taste, I mean the basic taste that's come from the tongue and the mouth. So sweet, sour, salty, bitter, and umami. And then think of the walls and the roof, so the significant proportion of that house coming from the sense of smell. And what happens is when food or drink is inside our mouths, molecules of it travel through the back of the mouth into the nose and detected by the receptor cells at the top of the nasal cavity. So when we're eating and drinking, we're actually smelling the food that's inside our mouths as well as tasting it. And by holding your nose, what you're doing is you're cutting off that flow of air, and you're therefore cutting off that flow of molecules.
So just to look at this in a little bit more detail, how does smell and appetite link? Well, before food's even touched your mouth, you will smell food. You're breathing into your nasal cavity all those molecules from the food. And these form a communication. So they hit the olfactory receptors, which are these yellow branch-like molecules at the top of the nasal cavity that are coming through. And these send a signal to the olfactory bulb, which continues the signal onto the amygdala and the hippocampus, which are areas in our brain which are involved in emotion, memory, and learning. So that smell is communicating an emotional message to us. From the brain, signals are then go which regulate our appetite. So we'll be producing more saliva in response to that smell. So saliva's got enzymes in, so our body is preparing itself to be breaking down to start the digestion process. We'll be producing more gastric acid in our stomach, so again our body is preparing itself. We'll have gastric motility. Interestingly, our body produces hormones in response to smell, so insulin hormone. So again, our body's preparing itself to respond to the food that's coming in. And also the hunger hormone, ghrelin, is produced in response to smells. So this is all encouraging our appetite. It's linking up to the emotion. And this is before food's even touched our mouth. So we're building a picture here. We're building a picture of, is this food safe? And is this food desired? Do I want to eat it? Which of course is so important for appetite. In our mouth, we're chewing the foods, we're breaking up those molecules. We can taste, we've got the basic taste. So for me, eating that jelly bean, I could taste the sweetness. But with my sense of smell, those molecules were going back up into the nasal cavity and I was getting the communication about the actual flavour. So again, I'm putting, there's more depth to this experience. The picture is growing. What I'm chewing, is it safe? Is it desired? And we've probably all been in situations where you start chewing a food and it's not desired. And you know, that's an important safety mechanism. Even then in the swallows, once the food has left our oral cavity, it's been swallowed and those molecules, those fragrant molecules have been pushed back up to our nasal cavity. Okay, so what happens in anosmia and smell loss? Well, quite often with a brain injury, the brain moves inside the skull, and this actually causes almost a grating effect of those olfactory receptors. So many of those olfactory receptors are lost in this process. So you're not getting this communication before the foods entered the mouth. So you're not getting those links with the memory, you're not getting that emotional response. Excuse me. You're then not getting these signals to your brain. Your body isn't preparing itself for the foods coming in. So you're not getting that increased salivation. You're not getting that gastromotility. And really, you're only experiencing the food as soon as it's in your mouth. So you're not able to decide if that food's safe, is that food desirable before it enters your mouth. And the chewing process, like the jelly bean experiment, you're getting the sweetness, but you're not getting the flavour. So you're not getting the depth of the experience. So why are smell disorders so important for us as a dietitian? Well, we're not just interested in the nutritional side of food. We're not just interested in filling up those storage rooms that I talked about before. The psychological side of food is really important, and as is the social side of food. Food is really complex, and we have to work in this middle area here. So psychologically, our relationship with food is really important, and our relationship with food often is affected by our memories. It's often affected by our emotions, and that's really important. We also need to know that food is safe. Eating a food that you don't know is safe has a really massive effect on us psychologically. So any decreased enjoyment in food is going to have a huge psychological input to us. If we're not enjoying food, if we're not wanting to be around food, if we're feeling different, if we're not feeling that connect with food, if other people are experiencing food differently, then that's going to lead to an isolation, and it's going to lead to a reduction in the social side of food, which has a huge effect on the complexity of food. So smell disorders will decrease the enjoyment of food, it will decrease appetite, and this will have a knock-on effect on the nutrition we're getting in. Decreased trust in food, decreased safety in food will have a huge influence on the psychological side, and decreased satisfaction of food. Now, food needs to be satisfying. After a meal, we need to feel satisfied by it. You've probably had experience of being full by food. You know you've eaten enough, but you're not satisfied. And that's a really difficult emotion, a difficult feeling to manage. If we're having a reduction in enjoyment in food and appetite, then we're likely to have an increased risk of malnutrition, so those storage rooms are going to be reduced. But if we're not feeling satisfied by food, then we need to find a way of using our other senses to make it more satisfying. So we might be adding more salt to it so that we can taste it. We might be adding more sugar. We might be adding more fat because that's got a good feel in our mouth. So this is all increasing the risk of obesity and heart disease.
So just following on from some of what Sean was just saying, the impact of olfactory loss. In 2013, Fifth Sense did a survey of our members to establish the quality of life impact of olfactory disorders, and that was published as a piece of research in 2014. And 92% of respondents in that said that their, unsurprisingly, enjoyment of food and drink had been reduced. There's also the sort of ongoing sense of loss, of being deprived of this really, really important emotional sense, and the loss of quality of life and accompanies that in all sorts of ways, as I outlined before, this feeling of detachment from the world around us and from life's pleasurable experiences. And then there's also some people suffer something called parosmia, which are distortions of the sense of smell. And this can make things smell very, very unpleasant. And it's something that's particularly common and with smell loss that's come with resulted from a virus, but people do get it following brain injury as well. I myself do still experience parosmia, albeit sort of fairly low level. There's the whole anxiety and depression aspects of this, loss of enjoyment of life. So going back to the survey that we did, 43% of people said that they'd experienced depression, 54% said they'd experienced relationship difficulties. And one aspect of that, relating it back to the eating experience, is that so many of our social interactions take place around a meal. So you take away the pleasure of eating and drinking, and people don't want to go out for dinner anymore to restaurants. They don't want to go around to have food with friends and family. It can be very, very difficult. And the other thing is as well, and again, I myself know, you lose memories of smells and tastes. I can't even remember what fresh herbs smell or taste like. I can't remember the smell of basil. So there's a huge range of impacts, partly on the eating experience, but much, much more widely.
Okay, so I just wanted to talk a little bit about a case study of one of my clients who has anosmia. So she is a female client in her 20s, and she had a traumatic brain injury following a road traffic accident, and this led to anosmia. She lives alone, however, she's very creative in the kitchen, she's very social, but also has some gastro symptoms. And here are some quotes. I asked her a few questions, and here are some quotes from her. So asking her about food at the moment, she says, some things don't taste as good, some simply don't taste how they used to. So there's this important kind of memory link here, that important emotional link, and the enjoyment of food. I asked her if she adds adds things to foods to make them taste better. She says sometimes hotter, slightly acidic. I think here she means chili hot. It's easy to be tempted to oversalt food, as it can really enrich the flavour. So fantastic here that she's noted that it's really tempting to add the salt. She's adding chilies instead, which is great from my point of view. However, she also has gastric symptoms as well, so that she might like the taste of the chilies, but it's not always great for the gastro tract. This next quote I thought was really sad coming from her, because she said, I try to stick with recipes when cooking for others. Now this lady is a really creative cook. She just chucks it in. She really experiments in the kitchen. And for her not to have the confidence to cook like that for her friends, I felt was really sad that she had to kind of follow this kind of recipe to know that she had the confidence to present it to her friends. From a safety point of view, she said food burning or pans overheating is a big issue. I try to be diligent with expiry dates, as I can't rely on smell. And I think the last one just sums it all up. It sucks, a big one.
Thanks, Sian. So some of the dangers and difficulties associated with olfactory loss. So starting with, there is this loss of confidence that Sian's mentioned, loss of confidence in one's own abilities to prepare a meal for friends or family. The whole safety aspect, I can't smell if food has gone off. If I'm worried about the milk, I have to rely on my flatmate to smell it for me. I borrow her nose, but not everyone has that. So lots of people live alone, and you've got to be really, really careful, making sure that food is hasn't gone off. Smoke and gas, of course, not being able to smell those. And we talked about this already, but the impact that it has on personal relationships, and the anxiety that it can come with socialising and not wanting to be as social, not wanting to take part in family gatherings that involve food. So what can we do? So going back to the beginning, I was talking about my interest in making use of our other senses to compensate for loss of flavour perception. Well, this is how we can do that. So basic taste becomes more important. People say to me all the time when I say, "Oh, I can't smell anything," does that mean that you can't taste? Because so many people think of taste as being the whole picture. And I sort of say, well, actually, my sense of taste is really good, but I've become really sort of quite good at detecting differences, very subtle differences in sweetness, sourness, saltiness, for example. So I'm not quite down to the last grain of sugar in my tea, but I am quite good at sort of detecting nuances in levels of basic taste, because that's kind of what I've got to work with, if you like. So I'm really focused on those. There's the trigeminal nerve, which is very much a friend to anyone affected by a smell or taste disorder. So the trigeminal nerve is responsible for all sensation in the mouth, nose, and face. It's what gives food texture, or where we detect the texture of food from. And it's also how we detect the temperature of food, and also spiciness. So the burn of chili and the sting you get from mustard in the nose, that's the trigeminal nerve being stimulated by different chemical compounds in those foods. Appearance becomes more important. All right, I might not be able to get the flavour of basil, but I still use it in cooking. So when I'm making tomato-based pasta sauce, I chop up the basil, tear it up, chuck it in there, because it's about creating, visual contrast, making the food more stimulating, given that I don't have the smell of it to stimulate my appetite. And then I think talking about it is really important, and this is something that people find very hard to do. But I would encourage, I'd encourage people affected by loss of smell to talk about what they're getting and what they're not getting, and talk about this with friends and family, and try and get them to understand. And through that, find things that work for you. And mindfulness, being aware of the things that you can still appreciate and enjoy, and focusing on those. And then finally, experimentation is really important. Try things that you've never tried before. Try things that you didn't used to like, because there might be things about different foods that you get something from that you might not be expecting to. Just try different things, experiment, and pay attention to the elements that you're detecting.
Thanks, Duncan. So what else can we do as well? So it's really important that anyone with smell loss after a brain injury goes through investigations. We shouldn't just put it all down to the brain injury. There can be polyps in the nasal cavity, which can reduce our sense of smell, and there can also be congestion as well. So there are some clinics. There are clinics across the UK that are specialist ENT clinics looking at the sense of smell and taste. And these can be found on the Fifth Sense website here, following this link. I'd just like to big up my dietitian colleague, Sherry Taylor, who's written a fantastic blog post on loss of the sense of taste and smell after brain injury, and I will retweet that on Twitter this afternoon, so keep an eye out for that. Mindful eating is really important. As Duncan's already said, it's about enjoying food, and it's about looking at all those other senses when it comes to food. So it's about getting the colours in there. How does a meal look? Getting different textures, getting different temperatures in a meal, so that we're really looking at those other senses when we're having a meal. And quite often I'll say to clients, almost when they're eating something, to really focus and really enjoy what they're eating, because that's really important. So I might even say to them, pretend you're having to write an article, a culinary article about your meal, even if it's beans on toast. Tell me everything about that beans on toast. Tell me about the colour, tell me about the texture, tell me about the temperature. And mindfulness is really important, because it's about feeling satisfied by that food. It's about having all that sensory input about that food and enjoying that food. There's also some great support provided by Fifth Sense, and Fifth Sense are doing a great job of raising the awareness of smell loss. So please do check out their website. There is some evidence to suggest that there can be neurogenesis of these olfactory receptors, and that we almost have to use them to get them back. So that this idea of smell training to assess where you are at smell. Have you got complete smell loss? Is there something there? Is it certain smells? And almost training the nose to pick up those and reform those neural connections again. So again, there's some great information from Fifth Sense about smell training. I'd also like to point you towards two books. There's this one by Molly Birnbaum called Season to Taste. And this lady lost her sense of smell following a traumatic brain injury. She was actually training to be a chef at the time, so very descriptive in her writing of flavours and taste, and this was a huge part of her life. So to lose the sense of smell was completely traumatic and life-changing for her. So I'd really recommend that as a book. The other one, which is more of a recipe book, is by Ryan Riley, and it's called Life Kitchen. And his mother actually went through chemotherapy and radiotherapy for cancer, and lost her sense of smell there. And he started cooking classes, cookery workshops for people in similar positions to really get their enjoyment back of food. So it's a real passionate recipe book there, which is fantastic. And also just to mention that Fifth Sense are running an online workshop on the 14th of December, hashtag Let's Talk Smell and Taste, which would be fantastic to get involved in to learn more. So just as we come to a close, I just wanted to end with a bit of food for thought. You may have heard the phrase, if you meet one person with a brain injury, you meet one person with a brain injury. And exactly the same is true for smell loss. Everybody responds differently to the smell loss, and this is why we need a real individualised, personalised approach to this loss. So just some examples here. Friends at school would say it's chips for lunch, and I would look around for the sign, and which I couldn't find. So kind of, you know, quite lack of reassurance here, isn't it? That, well, how do they know that there's chips for lunch? I don't. Yogurts all taste the same, really. It's more about distinguishing the texture rather than the taste of most foods. That's talking about other senses again and the importance. This one's quite interesting. Eating spicy food is like having a wall of fire in my mouth. So as Duncan was saying before, sometimes your other senses can actually become more heightened. So for this person, stimulating that trigeminal nerve is actually kind of over-stimulated for them. And this one, as a dietitian, I don't know if I find this really sad or really lovely. It doesn't really matter what I eat anymore, so I might as well eat healthily. It's kind of it's a real lack of enjoyment there, isn't there, around food, which is very sad.
So thank you very much for listening, everybody. I hope you found this useful and interesting. Just to say that Fifth Sense, you know, we really would like the brain injury community to be aware of the impact of olfactory loss, to ensure that the significance of this is taken into account in the ongoing treatment and management of patients. And you know, Fifth Sense is here to support you as professionals in doing that. If you'd like some more information, you'd like to get involved in our work, then we'd love to hear from you. Our contact details are there. My own email address is there. So please get in touch. Look forward to hearing from you. And again, thank you very much for listening.
Thank you.